Good morning, everyone, and welcome to the last neuroscience session for the conference. And this one is on Parkinson's disease. We have two major speakers, Professor Jae-Sung Kim from Asan Medical Center in Korea and Professor Kirk Fry from the University of Michigan. So I'd like to start by inviting Professor Jae-Sung Kim to the podium.
Thank you, Chairman. And ladies and gentlemen, I'm Jae-Sung Kim from Asan Medical Center, Seoul, Korea. It's my honor to be here and make a speech. Today I'm going to talk about FPCIT PET imaging in Parkinson's disease and atypical Parkinsonism. So my present is in three parts. First, I will give an introduction of FPCIT PET. Secondly, I will take a look at the FPCIT PET imaging PET findings in Parkinson's disease and atypical Parkinsonism. And lastly, I will present the clinical value of dual phase of FPCIT PET imaging. As you know, Parkinson's disease is one of the well-known neurodegenerative disease, and the key pathology of the Parkinson's disease is the generation of neurostriatal dopaminergic neuron. Death of dopaminergic neuron in substantia nigra results in dopamine transporter loss at the striatal dopaminergic neuronal nerve terminals. So many radio traces have been developed too. Among these, iodine 123 FPCIT is the most commonly used radio tracer in the world, especially USA and European country. However, in Korea, F18 FPCIT is the most commonly used radio tracer. F18 FPCIT and iodine FPCIT have the same chemical molecular structure, so have same affinity and selectivity to dopamine transporter. However, there are some differences in the physical property and imaging technique. F18 FPCIT has several advantages over iodine 123 SPECT. It has a high image resolution and shorter acquisition time. There is no radioactive metabolite passing BBB, and lower patient radiation dose, about 2.2 millisieverts. In addition, the preparation for thyroid blocking is not necessary before the FPCIT PET scan. And in Korea, the imaging cost of F18 FPCIT and iodine FPCIT SPECT is very similar. So in Korea, FPCIT PET is most commonly used. This is a PK data of FPCIT PET. FPCIT uptake of the striatum and occipital cortex increase rapidly after the injection. From about 10 minutes post-injection, occipital activity gradually decrease, and striatal activity increase or decrease according to the amount of dopamine transport density. The specific uptake curve peaked at about 2 hours in normal control, and the striatal specific to non-specific uptake ratio progressively increase over 2 hours in normal control. This kinetic feature is very similar to iodine 123 FPCIT SPECT, as you can see in the right side. So currently we obtained the delayed FPCIT image at 3 hours post-injection. At 2007, we studied phase 3 clinical trial for the assessment of efficacy and safety of FPCIT PET. The sensitivity and specificity of FPCIT PET was 100% and 97% respectively. So Korean FDA approved FPCIT for the clinical use at 2008, and FPCIT PET was partially reimbursed at 2015. This slide shows aging effect of FPCIT uptake. In normal control, striatal uptake decreased about 6% per 10 years. with even stratal uptake, as you can see. In contrast, Parkinson's disease, the aging effects Parkinson's disease show less aging effect. And our study with normal control and drug-naive early hemiparkinsonian patients, the symptomatic threshold of dopamine transporter loss in the putamen is about 30% of age-matched normal. So these physiologic finding and high-resolution PET image may contribute to our phase 3 trial, high diagnostic accuracy of our phase 3 clinical trial result. We also studied retrospectively the longitudinal decline of stratal FPCIT uptake in Parkinson's disease. As you can see, the annual decline rate of Parkinson's disease put to 11% according to the stratal subregion, most rapid in posterior putamen, followed by anterior putamen, caudates, and ventral stramen. And there was no significant difference between elderly onset Parkinson's disease and younger onset Parkinson's disease. In contrast, Parkinson's disease and secondary Parkinsonism or essential tremor decreased by less than 1% per year. It's aging effects almost. We use clinically dopamine transporter imaging with several indications. Among these, we use the dopamine transporter imaging for confirmation or exclusion of Parkinson's disease, and we obtain the prognosis of secondary Parkinsonism, essential tremor, drug-induced Parkinsonism, or vascular Parkinsonism. As you can see, secondary Parkinsonism show normal, but Parkinson's disease and essential tremor show decreased stratal uptake. However, the usefulness of dopamine transporter imaging for differential diagnosis of Parkinson's disease and atypical Parkinsonism remains controversial and still challenging. About 20 to 25% of Parkinsonian patients have atypical Parkinsonism, multiple system atrophy, and progressive supranuclear palsy. The most common etiology of the atypical Parkinsonism. In general, atypical Parkinsonism has rapid progression, poor response to L-DOPA treatment, and poor prognosis. They show typical clinical symptom and sign depending on the etiology. However, about 30% of atypical Parkinsonism is known to be misdiagnosed as Parkinson's disease because the characteristic clinical symptom and sign often not clear in early stage. Accurate diagnosis of atypical Parkinsonism is important to decide on treatment regimen and provide prognosis. So many conventional imaging methods have been tried to help the differential diagnosis in addition to clinical finding. As you can see, FDG PET is used for differential diagnosis of atypical Parkinsonism. Usually, Parkinson's disease show a normal-looking or non-specific diffuse cortical hypometabolism. However, MSA patients show typically posterior terminal hypometabolism or cerebral hypometabolism, and PSP patients show frontal and midbrain hypometabolism. However, this typical finding may overlap and may often provide insufficient information, and average PET scan is generally performed in addition to dopamine transport imaging. So if we can accurately diagnose only with dopamine transport imaging, it will be cost-effective and convenient for patients and clinicians. This is a typical MIP image of FPCIT PET of normal control and Parkinson's disease. As you can see, normal control show diffuse stratal uptake, caudates, putamen, and ventral putamen, ventral stratum. It looks like two rabbits in the brain. And Parkinson's disease, as you can see, there are asymmetric decreased uptake in the putamen, mainly posterior putamen, in transverse posterior putamen, and coronary scan, as you can see, the dorsal part of posterior putamen is more preferentially decreased. Voxel-wise and VOI analysis also show this trend. And as you can see, posterior dorsal putamen is mostly affected, followed by ventral putamen, anterior putamen, caudate, and ventral stratum. And this Parkinson's patients, it looks like two aliens in the brain. Okay. This characteristic epiphyseal PET finding results from the pathology in the substantia nigra of the middle brain in Parkinson's disease. As you know, ventrolateral part of substantia nigra, pars compacta, is preferentially involved, and dopaminergic neuron arising from this region innervates to posterolateral parts of the substance of the putamen, and the preferential site of dopaminergic neuronal loss in substantia nigra varies according to the etiology of Parkinsonism. In atypical Parkinsonism, such as PSP or MSA, this neuronal loss is more diffuse and pronounced in the medial and dorsal site of the substantia nigra. So we can expect that PSP or MSA may show different stratal uptake pattern in high-resolution dopamine transporter imaging. Let me show some case with atypical Parkinsonism. In this case, is a 70 years old female who suffered from gait disturbance and freezing for 2 years. Do diagnosis using epiphyseal PET alone? As you can see, there is a significant data loss in entire stratum except ventral stratum. In transverse image, you can see ventral uptake. In coronal image, the caudate uptake is severely decreased. How do you think that this case is advanced stage of PD? But the symptom duration is only 2 years. So the final diagnosis is progressive supranuclear palsy. Let me show another case of atypical Parkinsonism. This case is a 59-year-old male who suffers from gait ataxia and postural instability for 9 months. As you can see, there is asymmetric DAT loss in the stratum. In actual image, asymmetric posterior uptake, decreased uptake. But it looks like PD pattern. But coronary image, as you can see, right posterior putamen diffusely decrease. It's not relative sparing of ventral putamen. It's some different pattern of typical PD. The final diagnosis is multiple system atrophy. This is my study. Let me show another my study, and this figure is typical case of Parkinson's disease. As you can see, posterior the decreased uptake in posterior putamen and the relative sparing of the ventral putamen. And PSP show diffusely decreased uptake in posterior putamen and caudate nucleus, and the MSA it looks like a PD, but there is not relative sparing, no relative sparing of ventral putamen. Is, as you can see. So these pictures show percent BP of stratile subregion of Parkinson's disease, PSP, and MSA compared to age matching normal in our previous study. Using this subregional pattern, we can visually detect 78% of PSP and 67% of MSA with epiphyseal PET. Let me show another case of atypical Parkinsonism, that is pure echinasia with gait freezing. PHF is currently considered as a phenotypic variant of PSP. We evaluate the FP uptake pattern of PHP and compared with those of PSP and PD. As you can see, stratal uptake is very similar to PSP, not Parkinson's disease. In contrast to Parkinson's disease, the caudate uptake severely decreased. We think that this characteristic FPCIT finding supports that PHF is a phenotypic variant of PSP. Let me show another case of FPCIT PET, 8 years old male who has suffered from right leg dragging for 6 months. Can you make a diagnosis using FPCIT PET alone? As you can see, FPCIT uptake of anterior putamen is proportionally decreased, and relatively the posterior putamen uptake is sparse. It's not a typical PD pattern. But the clinical diagnosis is younger onset familial Parkinson's disease. You know, the familial Parkinson's disease show various pattern of the stratal uptake. So we cannot always make a difference, exact differential diagnosis between Parkinson's disease and atypical Parkinsonism using FPCIT PET alone. So we need another weapon for accurate diagnosis. In clinical circumstance, we obtained the FPCIT PET image during the pseudo-equilibrium phase to visualize and quantify the stratal dopamine binding of laser tracer, usually 3 hours later after injection in FPCIT PET. However, if we get the image at early phase, we can see the perfusion dominant regional uptake, as you can see. As cerebral regional perfusion is coupled to regional metabolism, this early perfusion phase imaging can provide FDG-like information. So we tested whether early phase, especially first 10-minute image, is similar to FDG PET. In Parkinson's disease, FDG and early phase FPCIT images show similar and normal distribution, as you can see. In contrast, MSA show regionally decreased uptake in bilateral posterior putamen on FDG and early phase FPCIT PET image, as you can see this here and this here. In voxel-wise analysis of early perfusion phase FPCIT image, statistically significant regional abnormality of early phase FPCIT image is similar to FDG in MSAP, MSAC, and PSP. In visual analysis of early perfusion image, we can detect FDG-like abnormality in 85% of MSAP and 77% of MSAC. So this early perfusion phase FPCIT image can be helpful to differentiate atypical Parkinsonism, especially MSA, in conjunction to atypical typical stratal subregional uptake pattern on delayed FPCIT image. Lastly, I will show you our preliminary study data. We evaluate the diagnostic accuracy of dual phases of FPCIT PET imaging for the differential diagnosis of Parkinson's disease and atypical Parkinsonism by visual interpretation and artificial intelligence using machine learning. As you can see, using delayed FPCIT image only, the diagnostic accuracy of visual interpretation and AI 81 to 85%. Using FDG PET only, the accuracy increased 93%, both visual and artificial intelligence. When we use the dual phase FPCIT PET image, the diagnostic accuracy of visual interpretation was 89%, is similar to FDG. But the AI the accuracy of AI increased to 96%. Although it needs further validation by large-scale prospective study, I think that dual-phase FFPCIT PET imaging is very useful and cost-effective for the differential diagnosis atypical Parkinsonism. In summary, the clinical use of FFPCIT PET scan has been increasing in Korea. FFPCIT PET is useful to confirmation of Parkinson's disease and also differentiate presynaptic from the presynaptic Parkinsonism. And the high resolution image of FFPCIT PET provides useful information for the differential diagnosis of atypical Parkinsonism, especially PSP, and dual-phase imaging can enhance the diagnostic ability of FFPCIT PET in the differential diagnosis of atypical Parkinsonism and can be cost-effective. Thank you for your attention.
I might take a few questions. We're not supposed to, but I've got a few questions. So, what dose of FPCIT PET do you use?
Dose? Yeah, we use 5 millicurie.
5 millicuries.
Yeah.
Okay. Is it a hard compound to synthesize? Do you know the chemistry? Is it difficult?
No, actually, our center developed a high yield method. So we FFPCIT is synthesized about 30%, 40%. So actually in Korea, about 10,000 patients perform the FFPCIT per year in 60 medical centers.
Okay. At Cyclotech, I believe, are making this compound. Is it up and running yet?
Second half of this year.
This will make it available in Australia under certain circumstances. But anyway, excellent, because it's obviously a terrific tracer. Thank you very much for that talk. I'd like to invite Professor Kirk Fry, who's going to teach us all about, firstly he's going to tell us about neuroreceptors and transporters, then teach us how to read that scan.
Well, thanks, I think. This is a bit of a landmine, I think. I was invited by the organizers to talk on this topic, but as you'll see, the update is potentially predominantly retrospective in that we haven't made major advances in this area, at least not those that clinically translate. And we'll talk about whether there's some reasons for that. But amongst the host of synaptic targets available in the brain to us in the neurosciences, there's a wide distribution of very focal tracer identification of specific neuronal structures and via specific interactors, but this sort of gives one the flavor of what different tracers may look like at different levels of the brain. And here's my very high resolution, so this is even better than FPCIT PET, of the typical presynaptic nerve terminal. And in it are articulated a number of potential targets that the field has made use of over the past 20 to 30 years. So there are enzymes specific to identified nerve terminals related to the processing and synthesis of neurotransmitter. There are transporters on synaptic vesicles that take the transmitter and package it for release. There are reuptake mechanisms at a number of synapses to terminate and recycle the released neurotransmitter. There are, of course, enzymes for breakdown of neurotransmitters. Some are located extracellularly associated with the synapse membrane. Some are intracellular, such as MAOs, for instance, and they are associated with mitochondria. And then there's the listening parts. So these are neurotransmitter receptors, and they come in fundamentally two flavors that we'll talk about just in a moment. So what I'm not going to talk about today are approaches to image presynaptic terminals based on specific synthetic or metabolic enzymes. So there's a synthetic one, and here are some metabolic enzymes. And looking at the neurochemistry of the brain, there are certain of these enzymes that are associated very specifically with identifiable phenotypes of neurons. But this is what we were invited to talk about, and so we have neurotransmitter receptors, and of course the ones that are of greatest interest are those that are located synaptically, and they come in two basic flavors. There are so-called metabotropic receptors, and these are transmembrane proteins that are affiliated with the activation of a secondary effector enzyme, usually a G protein related interaction. And then there are inotropic receptors, so these are ligand-gated ion channels, and interaction of the transmitter with these guys changes the membrane permeability to ions. So, what's good about neurotransmitter receptor imaging in our experience thus far? Well, the good news is there are just loads of lead ideas provided by pharma, largely. So up until the last 20 years or thereabouts, virtually all the drugs that had central mechanisms of action were receptor targeting. And so this provides a wide range of chemical structure activity for our radiochemists to select from and invent imaging probes for these sites. And this has led to literally, as I said here, hundreds of validated PET ligands targeting different subtypes of neurotransmitter receptors. But the bad news is that as we've thought about this over the decades, there are very few, if any, disorders that are really related to a primary neuroreceptor pathophysiology. So we don't have such diseases in our textbooks and in our knowledge base. And so the receptor imaging tends to be a secondary aspect of things rather than targeting the primary neuropathology. And then the other problem that we've encountered, particularly with those metabotropic receptors, the G protein linked guys, is that they tend to alter their expressed levels according to recent levels of stimulatory activity. So they downregulate when overstimulated, they upregulate when denervated, and so the actual number of receptor binding sites is not a simple relationship to the integrity of the nerve terminal. And then, as a consequence, partly of this, there at the present time are no receptor tracers that are approved for clinical use, at least in the US. Now, there's some dopamine D2 receptor ligands that are used in Europe, and I believe some of these may be reimbursed, but I'm not entirely clear on that. So I can show you examples of what might have been clinically translatable, although has not yet come to pass. And that is, for instance, the use of flumazenil, which targets the benzodiazepine binding site on the GABA-A receptor. And we and others have shown that in refractory epilepsy associated with or due to mesial temporal sclerosis, there's a profound loss of the GABA-A receptor in most of the hippocampal formation. So here is these are all in vitro studies. This is a post-mortem sample from a normal individual showing the laminar distribution of GABA-A receptor binding sites in the hippocampal formation. And these are samples from 2 patients who had their hippocampus resected as part of their epilepsy surgery. And you can see a profound loss, particularly in this dorsal aspect of the CA1, 2, and 3 sectors of the hippocampus. So in theory, if one wanted to do a more tailored resection of the temporal lobe for control of epilepsy, one could rely on this kind of imaging in a living patient. And here's a study of carbon-11 flumazenil in a patient with mesial sclerosis. And what you see is a focal reduction in the dorsal hippocampal formation compared to the contralateral side. And this indeed, when removed, stopped the seizures. In conjunction with Dr. Satoshi Minashima, when he was part of our group, we developed a stereotactic rearrangement of individual brains to a common atlas format. And what you see colored in here, if we selected patients who had left mesial temporal lobe epilepsy, the colored voxels are where they demonstrated a statistically significant group reduction in their GABA A receptors. And so to take this forward, the issue would be, is on an individual basis this kind of information useful in tailoring a neurosurgical intervention? And we tried for a while to get this to play out in the clinic, but quite honestly, the neurosurgeons, at least at our institution, are very fixed in their ways. They know how to stop these seizures from occurring with the current surgical approach, and they were not terribly interested in pursuing this more refined approach. But I could show you an example of where this did potentially have clinical impact. This was a patient in our epilepsy clinic who underwent an FDG glucose metabolism scan as part of their preoperative evaluation. And you can see here there's an obvious defect in the frontal lobe in the left hemisphere. This had not been observed on the patient's MRI because in those days we did coronal MR primary acquisitions through the temporal lobes, and this part of the frontal lobe had been cut off, so it was not imaged. But on the FDG, there's obviously a lesion there. We went back and did a typical axial MR cuts, and it turns out that this was a low-grade tumor. It was a ganglioglioma, and the assumption was this was the epileptogenic focus, and so it was removed. Well, the patient, after surgical recovery, did not have reduction in their seizures. The flumazenal scan that we did in the same patient, of course, showed no GABA receptors in the ganglioglioma here, but it showed also the typical reduction we see in mesial sclerosis in the left hippocampal formation. The patient then returned to the operating room several months later and had a typical amygdalohippocampectomy, and that caused complete resolution of their seizures. So this kind of surgical planning, I think, is a window for the use of benzodiazepine binding site studies. And I know here in Melbourne there's a group introducing a fluorine-18 labeled derivative of carbon-11 flumazenal that would potentially have the sort of clinical application and portability, at least amongst centers located closely. So I think this kind of use of receptor imaging, although has potential, has not gained a clinical translational foothold. On the other hand, there's a very intriguing use of receptor imaging that's predominantly provided insight into neural mechanisms that are not approachable by any other means, and these are a really important source, I think, of unique information. The best examples of this come from dopamine D2 receptor ligands, and this is exemplified here in actually out of a research article that was published by Marc Laruelle, one of the investigators who was very interested in defining this phenomenon. So what you see here is a typical time activity curve during a continuous infusion of carbon-11 raclopride, and so there's a relatively steady state level of activity in the putamen and here in the cerebellum for a point of reference. And after establishing this steady state, the patient is then injected intravenously with a dose of amphetamine, which causes release of dopamine from presynaptic stores. And what you can see is a response to the amphetamine injection is a fall in the receptor labeling within the putamen. We know from in vitro studies that amphetamine does not directly interact at all with dopamine D2 receptors. So the interpretation of this is that what's happened is the synaptic dopamine level has risen and it has competitively reduced the available binding sites for the radiotracer, so that under the baseline conditions you have D2 receptors. Some of them are occupied by dopamine and some of them are available for raclopride PET binding. If you do something to stimulate the presynaptic release of dopamine, you get more dopamine occupancy and there are fewer receptors available for the radiotracer. And conversely, if you have a situation where you've depleted presynaptic dopamine, you get increased binding. And this is a unique insight that can be approached only similarly in experimental animals with microdialysis studies. But this makes this available to us in the living human brain. So what has this shown us? Well, I won't show you slides of schizophrenia, but the dopamine hypothesis in schizophrenia, that dopamine is at least dysregulated, if not upregulated, in schizophrenia, is sustained by these kinds of studies where schizophrenics have a more robust inhibition of their raclopride binding by amphetamine challenge. Less well believed, though, in the neurosciences, perhaps until this series of studies, is a similar dysregulation in patients with Tourette syndrome. And here Dean Wong and his colleagues compared the effects of amphetamine stimulation. So here's the control curve. They did bolus injections and estimated a volume of distribution. And here's the control curve, and then here's one of these individuals following administration of amphetamine and a separate PET study. And over here mapped is the amount of reduction that was seen following the amphetamine challenge. And you can see there's quite a degree of variability, but these are normal volunteers that were recruited. And here are a collection of Tourette subjects. And you notice that particularly these guys down here have a more robust response that's way outside the range of normal. So this gives insight that at least a portion of Tourette syndrome patients similarly have a loss of regulatory control of their synaptic dopamine levels. But of even more interest to me as a movement disorders neurologist is this kind of data. And a lot of this comes from John Stossel at Vancouver, this from Paula Piccini. In this case, we're following the function of a neural transplant. So you may remember about a decade ago, there was great enthusiasm for fetal midbrain transplants into the striatum of Parkinson patients to relieve, in part, their dopamine deficiency. So here's an F-DOPA scan. This is a Parkinsonian patient, and on this side there was a series of implants into the posterior putamen. And in this setting, if you do a raclopride scan, you find that perhaps there's a little asymmetry here in the striatum, and that's probably because on the ungrafted side, the dopamine levels are low, and so there are more receptors available, so you see asymmetrically increased binding. If you then give an amphetamine challenge, however, in a normal individual, you get a bilateral and pretty profound reduction in the raclopride signal. Whereas in this transplant patient, the untransplanted denervated side changes little, if any, whereas the side with the transplant now shows a profound reduction. So this transplant is functioning, and it's actually releasing dopamine that interacts with synaptic dopamine receptors. So this was a critical aspect of evaluating the effects of these transplants, because clinically it was determined that while there was some detectable clinical benefit overall, these transplants didn't improve management of Parkinson's symptoms very effectively. And one question was, of course, do the grafts actually survive, and are they actually doing what they were intended to do? And the answer was yes and yes. So the reason for this failure is more sophisticated than a simple failure of the cells to survive. Now, of even greater interest to me, the main medication approach that's used for Parkinson's disease, as I'm sure you all know, is carbidopa-levodopa, or brand name called Sinemet. And when one treats a Parkinson patient over years with Sinemet, several problems may arise. The first of these is end of dose wearing off, which is here demarcated as a fluctuator group. And what John Stossel and his group did was to take a group of mild to moderately severe Parkinson's disease patients from their clinic, and they used the administration of levodopa instead of an amphetamine injection to trace the levodopa effects on synaptic dopamine. And each of these clusters of bars is one of their patients, and they determined the effect or the availability of dopamine receptors at baseline, and then following a significant oral dosage of levodopa at 1 hour, and then again at 4 hours after that dose. And you can see there are two patterns that emerge looking across these 8 patients. One is where the effect is rather monotonous and seems to be greatest seen at 4 hours compared to 1 hour. But there's another pattern where there's a bigger decrease at 1 hour with a recovery or a return back to baseline at 4 hours. When they followed these patients for 6 months, it turns out that approximately half of them developed this end of dose wearing off, or so-called fluctuation, and the others retained a sustained response to the levodopa. And you can see that the fluctuator group, the blue guys, had a much bigger effect shortly after administration of a dose of the drug, which was completely lost 4 hours later, and this is associated then with the return of their Parkinsonian symptoms. But this pharmacokinetics anticipated the development of that clinical feature by at least 6 months' time. Even more interesting, a more disabling side effect of the use of levodopa in Parkinson's is the development of medication-induced extraneous movements, so-called levodopa dyskinesias. And for those of you who have seen Michael Fox, the actor, on television loops or news loops these days, he has very profound neck and head dyskinesias where he moves in an unusual looking way, and this is a manifestation of his high medication level at that time. And what Stossel was able to show is that the patients who demonstrate these dyskinesias in response to an appropriate Sinemet dose have a much higher release of dopamine initially, and then it tends to more or less normalize by 4 hours post-administration. But it's this early release and response following an oral dose that tracks with the timing of when patients are dyskinetic. So this kind of information is unapproachable in humans other than with this kind of an approach, and this is really a novel use, I think, of neuroreceptor binding. Now the issue is, though, we'd really like to do this at a wider array of synapses. Dopamine is important in movement disorders, but there are many other neurotransmitters we'd like to be able to transduce in a similar way. There is evidence that the opiate peptide system perturbed by or measured by C11 carfentanil can tell us the same thing about endogenous opiate release. And there's some evidence, although not yet reproduced, that cholinergic synaptic, that acetylcholine in the synapse can be transduced by one of the newer nicotinic receptors. So, neurotransmitter receptor imaging, predominantly research applications. Target engagement by therapeutic drugs in pharma and development is actually a heavily engaged use, but many of these results are held in confidence. And then measurement of endogenous synaptic neurotransmitter, I think, is a very attractive and ongoing research use. Possible clinical applications, well, generalized synapse loss transduced by something like the GABA benzodiazepine receptor. And there is some, although controversial, evidence that decrease in dopamine D2 receptors may help to segregate between some of the atypical Parkinsonian syndromes we just heard about versus idiopathic Parkinson disease. But this, as I said, is controversial, and some studies fail to support that this is an effective use. So I'd now like to turn to the other target of this talk, and that's synaptic vesicle proteins. And this has been an area in our laboratories where we've had a very significant interest, and it's been fun. What we targeted first, well, actually, first and longest in our laboratories, is the vesicular neurotransmitter transporter for monoamines, the so-called VMAT. There are a number of cloned similar transporters for a wider variety of neurotransmitters. For the acidic amino acid transporters, we don't have target ligands that interact with the vesicular transporters yet, and the question is whether they will become available. Not sure. But VMAT2 is the transporter that's seen in all of these monoaminergic neurons and is traced by a tracer introduced by Mike Kilborn in our laboratories, carbon-11 dihydrotetrabenazine. This is a molecular analog of the fluoropropyl agent that Dr. Rowe and his group have been pursuing. And then I'll show you at the end some studies on the vesicular acetylcholine transporter. And the nice thing about these vesicular transporters is they are indeed localized in a specific neuronal subtype, and specifically in their presynaptic terminals. And so there's a considerable degree of specificity offered here compared to some of the neurotransmitter receptors and their distributions. So to start with VMAT2, the research studies we've done in our laboratory have all employed carbon-11 dihydrotetrabenazine. This is a cartoon of the 18F-AV133, which is the fluoropropyl derivative of this same tracer. And here's what you get in the brain. You inject. It is initially deposited according to delivery by blood flow, but as time progresses, the binding and retention becomes quite strikingly selective in the striatum. And what we've found is that just as you heard with regards to the fluoropropyl CIT, there's a difference between normal control individuals and those who have Parkinson's disease, where the reduction is predominantly in the posterior putamen and is asymmetrical. We see also more symmetrical reductions throughout the striatum in dementia with Lewy bodies. And for contrast, in Alzheimer's disease, there is no significant loss of nigrostriatal projections. So this tracer allows us to make a nice distinction between these two dementias and allows us also to study Parkinson's disease as it evolves. Now, with regards to the vesicular acetylcholine transporter, this is our canonical target tracer. This is a fluoroethyl methoxybenzovicamicol. So this structure is vicamicol, and here's our radiolabel in the alkyl group. This has a little slower kinetics, so it's nice that it's fluorine 18 labeled. So we've imaged this out for several hours post-injection, and you can see that it, first of all, does not clear or leave net from the basal ganglia where the binding site is most heavily expressed, but it at least achieves a relative plateau of activity, and this can be kinetically analyzed, which we've done. It turns out, though, that a late static image is very highly reflective of the binding capacity. And so what you see here in the top row are FeOBV activity levels through the striatum in the middle. So these are from top of brain to bottom of the brain. And you don't see much other than the striatum, where the acetylcholine presynaptic terminal density is extremely high. If you scale these images up by a factor of 3, you can now see the rest of the brain. So we see signal throughout the cerebral cortex. Interestingly, there's probably a little more signal in the amygdalo-hippocampal formation than in the rest of the neocortex. But this allows us to gain a window onto the rest of the cholinergic projections and innervation in the brain. So far, we've applied this predominantly in Parkinson's disease, where we know that cholinergic neurons, both in the basal forebrain and also in the brainstem, are lost as the disease progresses, and this gives us a window into this progression. So here in the top row is an average of, I believe, 6 patients with Parkinson's disease, and here's an average of 6 normal controls of similar age. And you can see with setting the window very high that there is a little loss of signal within the striatum, but not much. Whereas if we now scale things up by a factor of 3, you can see that there's really a very diffuse and profound loss of presynaptic cholinergic innervation of the neocortex, particularly also of the amygdalo-hippocampal formation. And these losses have clear cognitive correlates in terms of patient performance. So we're pursuing this further. The other thing that's of interest to Nick Bowman, who's the investigator in our lab most focused on this, is this loss of innervation in the thalamus, in the diencephalon, correlates very well with loss of postural reflexes in patients who have falling that does not respond to dopamine replacement. So we believe that the brainstem projections, cholinergic projections, are important for maintaining posture and balance and are lost in patients with Parkinson's that have this difficulty. Let me just finish, though, with some really, I think, exciting work that has emerged over the last 2 years. This comes from the group at Yale University led by Richard Carson. And what they've done is identified a new target, so this protein SV2A, which is a synaptic vesicle protein that's involved in vesicle cycling and docking in the nerve terminal. And the theory underlying this is that SV2A is part of synaptic vesicle anatomy, and that its concentration is not regulated, and it really, the amount you have in your hand tells you how many synaptic vesicles you've grabbed. And they have invented a radiotracer which targets this site. They've titled it, and I don't have its structure for you, but it's UCB-J. And they've done a large number of studies demonstrating the pharmacokinetics and modeling of this. But this is the first disease-related report of this agent's activity. And what you see here, kind of, in the MR is a little increased signal in a hippocampal formation that's sclerotic. And here, just as I showed you with flumazenil, is a very focal but significant loss of SV2A binding in the sclerotic hippocampal formation. So this agent has the possibility of being even more specifically targeting synaptic neuropil in general, as opposed to relying on GABA-A receptors to reflect that same thing. And I think this is likely to nicely offer additional evaluation to what FDG may provide, again telling us specifically where is there loss of synaptic neuropil in a given patient such as this, pre-surgically evaluated, but also in neurodegenerative diseases to objectively measure the loss of synapses that may accompany the deposition of tau and or amyloid or other proteinopathies. So, what I think I've said, there are a very wide range of synaptic neurochemical targets that have been successfully probed by PET tracers. Novel insights into the involvement of specific receptors, neurons, and neurotransmitters are now feasible and have been feasible for some 2 to 3 decades. But at the present time, we're limited by direct clinical diagnostic translation of these methods, and we really need to think long and hard about whether we've overlooked some potential applications we should now pursue. So I'll conclude there.
A quick question. The synaptic market you just showed,
yep,
has it been compared to FDG? Because FDG uptake is supposed to...
You would say it's the same. Activity. So to my knowledge, it is not yet, or at least they haven't released the result. I should have said it. This is a radioligand that's structurally related to levetiracetam, which is an anticonvulsant that interacts with SV2A, and so it's mechanistically related to that. I would predict that it will reflect largely the findings with FDG, but it's probably more objective in that with FDG, if you reduce the activity in a pathway, you'll lose the FDG signal, whereas here it will tell you whether or not the synapses are still physically present and just underactive, or whether they're gone.
Right, okay. Do we have any other burning questions before we move on to the cases?
Well, there's one more. Did you want to go on to the... It doesn't matter.
Got another lecture.
Well, that's all right. We can do it very quickly.
Okay.
All right.
Let's teach us how to read that.
Part 2. Well, it says how to read that, but that would take only 2 seconds, because I can show you this is positive, this is negative, and it's done. So I thought I'd make it a little more interesting to focus on presynaptic dopamine terminal imaging. And as you know, there are 3 different distinct targets that have been approached in this area. First of these was to label a false transmitter with F18 fluorodopa. And this was introduced by Canadian chemist Gunther Furnau, I think in the 1980s. The next, and here is an example of fluorodopa showing that it's relatively unaltered by normal aging, and we think this is because the target enzyme, aromatic amino acid decarboxylase, is regulated in its activity, and so as we get older, if you have slightly fewer nerve terminals, those that are left are working hard to make up. The second target, or a second target that has been introduced, is this vesicular neurotransmitter transporter that I spoke to you about briefly before. And again, here are the ligands that target that. Here's what I didn't show you, and that is the effect of age, where successful normal aging does produce a reduction in this signal, just as we know with the DAT. And in Parkinson's disease, though, the reduction is profound and nothing like the aging effect alone. What we know about this is that it's not specific to dopamine terminals, because all monoamine terminals express this. But we do know from experimental animal studies and from postmortem human studies that well over 95% of the striatal signal is attributable to dopamine terminals. And it's not readily regulated by drugs that are used to modulate the activity of dopamine neurotransmission, so it doesn't have pharmacologic interactions of significance for us to worry about. And here's a study from our laboratory now several years ago showing the age-related effect. This is about the same as what we heard was true for the DAT, so about 5% per decade loss. There's no gender difference, so one of these symbols, I think the open ones are female, the closed symbols are male. And the squares down here are patients with mild Parkinson's disease, and there's clearly no overlap between those. In this gray box are individuals that are now depicted here. So this is an average of those normals. This is an average of those Parkinson's disease patients. And this is the statistical map showing where there are differences between these. But here's the really interesting thing, and that is if one gets the power of numbers, you can actually see in the statistical maps loss of binding in the substantia nigra, or at least in the ventral midbrain of these patients. Now, to switch gears to AV133, which has been pursued by Dr. Rowe and his group here, and as well by our group. So this is the fluoropropyl derivative of tetrabenazine. Here's the appearance in the normal, and this does allow you in a single patient, based on F18's nice resolution characteristics, to see the midbrain. And then here are a series of Parkinson's disease patients showing, as I did with carbon-11, profound losses throughout the striatal complex, as well as in the midbrain. And then here's a patient with dementia with Lewy bodies showing, again, severe bilateral, relatively symmetrical loss. And the question is, how does one go about quantifying this? And the answer is, well, you can do a kinetic estimate of binding potential with the Logan plot, which we applied as out to 90 minutes. But if you simply look at the SUVR relative to the occipital cortex, you get virtually the same effect size in Parkinson's disease. So a simple inject and wait an hour or so and make an image seems to capture the majority of what one would want to know here. Now, the third is what we already heard about at in the first talk, so I won't belabor this too very much. But at least in the States, the target ligand is I-123 labeled, not fluorine 18. The DAT binding site is, as opposed to VMAT, the DAT is specific to dopamine terminals, but unfortunately the radiotracers are not completely specific to DAT, and many of them share activity at serotonin and norepinephrine reuptake sites, although of lower affinity. So here the lack of specificity is conferred by the tracer, not necessarily by the expression of the protein. We know also that the DAT cycles from the cell surface to endosomes, and this is directed by its differential phosphorylation, which in turn is related to presynaptic dopamine receptor activity. When the DAT is internalized, it is not available to these cocaine analog ligands, and so you may theoretically see a reduced DAT concentration due to high synaptic dopamine levels as opposed to loss of terminals. I think this is a relatively minor effect, but in research studies it's important to bear in mind. So here's ioflupane, and you just heard that in Korea, the fluorine 18 label is placed here, and in North America, the I-123 label is placed there. And this is what you see in the images. So these are far less resolute than what we were shown with the PET. So this is partly resolution in SPECT, and well, that's what it is. This is a patient with Parkinson's, though, showing an asymmetric loss in the posterior putamen. In terms of, quote, reading these scans, the drug manufacturer recommends that you look right through the middle of the striatal complex and that you should see a comma in the left hemisphere, and in the right a reverse comma, so you see a dot for the head of the caudate nucleus and a tail for the putamen. This appearance is because of the resolution of the SPECT scan. So when we have PET, you see that the putamen intensity is much higher. And then there are a series of, quote, abnormal patterns, where here's one where the caudate nuclei are relatively conspicuous and there's an asymmetric loss of the posterior putamen. Here's one where this is more advanced, the putamen has gone missing entirely. And finally, one where in more advanced stages of degeneration, the caudate nuclei are significantly affected as well. From a differential diagnosis standpoint, the patterns that we saw with the F18 PET are not able to be recovered from the SPECT studies with reliability. So to say that another way, the distinction between the Parkinsonian neurodegenerations that we saw with F18 fluoropurple CIT are not able to be made reliably with DAT SPECT. So how do you do I-123 iodine imaging? As we heard, it's important to block thyroid with SSKI. There's not a lot of deiodination, but it does occur. In our laboratories and throughout the US, we employ about a 5 millicurie dose, and then there's a stable distribution after 3 hours, so you do a SPECT scan at that time. What we do in our laboratory, though, it's recommended that you acquire for about 30 minutes to get enough counts to do an anatomically reasonable reconstruction. We usually break the 30 minutes up into 5-minute intervals, and that's because even the most well-intentioned of patients have a hard time holding still for 30 minutes. And if they move, it completely degrades your reconstruction. So what we usually do is, without attenuation correction, reconstruct each of these 5-minute intervals, and we observe whether there's motion between them, and we will throw out the frames that don't align with the majority of them. To make this even easier, we employ fiducial markers, so we put about a 5 to 10 microcurie dose on a piece of filter paper and place it on the zygoma on each side. And if that resolves into a dot, you know the patient held still. If it resolves into an arc or an ellipsoid or something interesting, you have a motion problem, and you should think about throwing out at least some of the data. And then the other issue that's not dealt with often is attenuation correction. And of course, you have to attenuation correct these images. The question is how. So if you do an assumed attenuation using Chang, you will get different quantitative values than if you do a measured attenuation with a CT scan. Not sure whether that's really critical or not unless you're going to employ quantification. But here's a typical study. This is a normal result. But if you carry this down below the base of the brain, these two metastatic foci are our little zygomatic markers. And you can see in this study they were well resolved as a focus, and so this reconstruction is without the intrusion of significant head motion. So, to summarize, the terminal markers, they have distinct molecular targets, but they're all able to distinguish clinically relevant dopamine lesions. And why is that? Well, because you have to have at least a 50% loss of dopamine neurons, and probably closer to 80%, before clinical signs and symptoms are manifest. So any patient who's referred to us with a question of Parkinson's disease, you expect to see a severe reduction, and it really doesn't matter which of these terminal markers you've chosen to employ. And again, we think that the most likely potential clinical uses, Parkinsonism versus essential tremor, although this is often solvable in the clinic. I think the most impactful use is in the dementias, which we're not going to talk about further today, at least I don't think so, but in separating Alzheimer's disease and frontotemporal dementia, where these projections are largely preserved, versus their pretty profound loss in patients who have dementia with Lewy bodies. So amongst the movement disorders, we've heard about this already, so nigrostriatal degeneration is characteristic of all of these. Most of the patients are idiopathic Parkinson disease, but about 10% of patients referred to movement specialty clinics have either PSP, multiple systems atrophy, MSA, or cortical basal ganglionic degeneration. But at least with the DAT scan SPECT, these conditions cannot be reliably separated one from another. On the other hand, if you're seeking to differentiate between these guys and alternative diagnoses that don't have dopamine neuronal pathology, you can clearly see the intact projections in patients with essential tremor. Sometimes useful, those with drug-induced Parkinsonism as opposed to Parkinson disease. Isolated resting tremor, which is a Parkinsonian variant but does not progress to develop bradykinesia and rigidity. It's simply the rest tremor of Parkinson's. We don't really understand it very well. And those patients who have tremor because of dystonia, so if they have limb rigidity unrelated, they can have a propagation or a tremor that can be difficult to separate sometimes. This is a nice review I'd refer all of you to if you're going to get into this field, regardless of what tracer you use. This came from the Journal of Nuclear Medicine some years ago, 2013, Klaus Tatsch and his co-author. And it nicely shows the intact nigrostriatal projection in these cases, so essential tremor, drug-induced Parkinson's, and normal pressure hydrocephalus. It shows an unusual pattern with this middle of the putamen loss on one side in vascular Parkinsonism, where the MRI scan would have shown you the lacoon. And then in these neurodegenerations, where really you cannot reliably tell from the pattern with DAT SPECT whether you have a PD patient, a DLB patient, MSA, or PSP. But you can certainly tell it's one of these. Patient prep for these, for the DAT scan, only the SSKI, but nothing beyond that. But there are drug interactions with these, and for VMAT2, you certainly want to take the patient off tetrabenazine. And we find that patients who have previously received reserpine may have a substantial reduction that persists for years. So it's important to take that drug history. And if they've been reserpine treated ever in the past, one should expect to see a reduced signal intensity. With the DAT scan, psychostimulants that interact with that same site need to be discontinued, and they need to be discontinued for several half-lives in order to get them out of the system. And then the issue is you probably, if you're going to quantify, which we don't in our labs, but some do, if you're going to quantify, you need an age-adjusted normal range for DAT scan and probably also for VMAT2. So, despite lack of a head-to-head competition and comparison, ioflupane versus 18F AV133 and versus 18F FPCIT, I think the PET agents perform comparably but have better image quality. The dopamine terminal imaging does separate groups of extrapyramidal movement disorders but does not identify a specific diagnostic entity, perhaps unless one does the PET approach. And clinical applications then require an experienced practitioner on a patient-by-patient basis to get maximum scan impact. What we see in our clinics is that there are a lot of referrals which are really medically not sensible, and sometimes counseling the referring doctor about what you can and can't do with these procedures is paramount. Okay, now we can do
I've got one question again.
Oh, not again.
Jason and Kirk,
Yeah.
if you're quantifying, how much reduction do you accept as normal? Is there a Z-score or a percentage reduction that gets you thinking something's going on?
So if one's talking about for clinical purposes, I think if you don't see it with the naked eye, it doesn't help to put a number on it. Now, this is not true necessarily of the patterns that one sees with voxel-based analyses. It turns out, though, that a 4 to 5 standard deviation reduction equates to where you start to see threshold Parkinson disease pathology.
Okay.
So it's not subtle.
Right. What about in dementia with Lewy bodies where they may not yet have symptoms? When do you get excited?
So I dropped off that slide, but it turns out that in DLB, at least in our experience, the same degree of reduction is within range, such that maybe they have a 70% reduction, not quite 80, so they may not be Parkinsonian on exam, but they have the lesion and it's demonstrable.
Okay.
At least that's my belief.
Right. Okay, so if you find a 40% reduction, what do you think?
Well, I think it's not symptomatic.
Right.
I think if it was a demented patient, I'd be concerned that they may have DLB. So what we do with our dementia series is we set a 95 percentile confidence interval, and if you fall below that, we say that's abnormal. But we don't expect to see Parkinsonian features on examination until
Right.
you get way below that.
Thank you. All right, we'll move on to the Read with the Experts.
Uh-oh. Well, I'll try not to take the entire day, but maybe we can go through 3 of them or something and then
Okay, yeah.
change. Oh, it's here. My goodness. All right, so I prepared a couple of case studies for us. I actually had to cull through our clinic archives to find cases where I think there might be a management impact, so bear with me here. So the first of these I want to show you is a 35-year-old patient with DeGeorge syndrome, and I heard about this in medical school, but I'll be honest with you, by now I've completely forgotten it. But this is a dominantly inheritable but frequently spontaneous mutation, deletion of 22q, and it's associated with short stature, congenital heart disease, neurologic impairment, usually due to attention deficit hyperactivity. Some patients have a more complex picture, as this one did, with some structured misbeliefs and psychoses. And then a minority of these patients can develop nigrostriatal degeneration. And this patient was referred to our clinic because of development of bimanual dexterity problems, had trouble with buttoning buttons on her clothing, and had difficulty dining with use of a knife and fork for dining. And so was on methylphenidate and pimozide for her neuropsychiatric impairments. And the question was, is this person one of those that has the Parkinson lesion? So, what preparation was needed prior to doing this scan? Discontinuation of pimozide, administration of SSKI, discontinuation of methylphenidate, or both B and C. So who votes for A? No hands. Who votes for B? Well, it's true, but it's not the best answer, is it? And what about C? Similarly true, but not the best answer. How about D? Good, we've all been paying attention. So you do both SSKI to protect the thyroid, and you get rid of the Ritalin so that you have a target you can image. And so we did. Now, these scans are read differently by all of us who have our preferences about, pseudocolor versus grayscale and so on. So for each of these, I'll show you 3 depictions of the same scan data. So here's the grayscale. These are transaxial, extending upper left base of brain to lower right mid-ventricular or supraventricular levels. Here it is in the rainbow color spectrum, and then here it is in the warm metal format that seems to be favored by many here. So seeing this scan picture, the question is, what's your best interpretation? Moderate reduction in striatal DAT, allowing for Dr. Rowe's careful questioning about how much reduction one needs. Severe reduction, normal DAT expression, or we failed to eliminate the interference from methylphenidate. So how many go A? Okay, B, and C, and D. Oh, we got votes all across the board. So with SPECT imaging, as opposed to the really nice crisp images we were shown with the PET, this degree of reduction is negligible. In fact, it's completely normal. So you can see, you can see the posterior putamen throughout. So it's a nice period with a comma. So this is the normal appearance of a DAT scan. And in this case, the question now is, what should we do? So what we think here is that the Parkinsonism here is a side effect of their antipsychotic. And if one needs to continue that to suppress their psychotic belief structure, then one should change the pimozide, which is a fairly potent anti-D2 antipsychotic, to something like quetiapine, which is an atypical but with very low affinity for D2 receptors, or perhaps stop altogether. But there's no role for administering Sinemet or other dopamine replacement medications in this patient. All right. We have a 35-year-old male who was referred. He had a mild closed head injury followed by a multitude of complaints, including chronic headache, neck pain. He had some limb rigidity and difficulty with bimanual dexterity. He was on a whole boatload of medications targeting his rigidity and headaches. The question arose, is there evidence for nigrostriatal pathway damage? And here is his DAT scan, and here it is in color, and here it is in warm metal. And what do you think? So what management is indicated by the result of this scan? Discontinuation of his memantine, administration of levodopa, administration of ropinirole, or continued rehabilitation support. So who votes A? Good. Who votes B? Good. Not falling for this one. And how about C? No. D? Yes. And maybe referral to a different psychiatrist. All right, let me, so it's normal. There's no role for dopamine replacement here. His presynaptic terminals are just fine. Let me conclude with this case. This is an interesting one. Almost 60-year-old male with a 2-year progression of limb stiffness. He has impaired short-term memory and impaired visuospatial abilities. On examination, he has upper limb rigidity and bradykinesia. He has postural instability. He's easy to knock over in the clinic. But the rest of his exam, including brainstem examination, is normal. He's been placed on dopamine replacement therapy with pramipexole, and he's been administered resagiline, an MAO-B inhibitor that are typically employed in Parkinson's disease, but he has not yet reported a symptomatic benefit from these medications. So the question is, what's the question here? So here is his scan. And now that you're all expert in reading these, I'm sure you've formulated your opinion as to whether this scan is normal or not. But what's your most likely diagnosis? So is this idiopathic Parkinson's disease? Is it a Parkinson plus syndrome, cerebrovascular disease, or Alzheimer's disease? So A, okay, some vote. B, right, you listen to the clinical history. C, not so much. And D, well, I had to have a fourth foil. So you're right, there's severe bilateral degeneration. A subsequent trial of converting him to Sinemet therapy was also not helpful. Following over years in the clinic, though, 2 or 3 years later, he had marked progression of his rigidity and had falls to the extent that he broke a hip. He also developed swallowing difficulties. He had dysphagia and dysarthria, and finally developed a gaze abnormality, a supranuclear vertical gaze palsy, which allows us to confirm the definite diagnosis of progressive supranuclear palsy. Let me stop there, and you can show your.
Yes. I have a poor case, but it's very simple. But in clinic, we usually experience. Let me, before starting the case review, I will remind you of a typical FPCIT uptake finding in normal scan, in normal, the axial and coronal, and the axial image of the midbrain level, as you can see here, diffuse caudate and putaminal uptake, and the midbrain level, as you can see, you uptake in the bilateral substantia nigra, and serotonin uptake on the midbrain level. In Parkinson's disease, you can see asymmetric reduction of posterior putamen in axial image and coronal image. You can see the right side reduction, especially dorsal part of the putamen. It's a typical usual PD pattern. Okay, let me first start my first case. 60-year-old female with gait ataxia for 1 year and resistant antibiotic anesthesia. He suffered from urinary frequency and unstable tandem gaits. Physician ordered MR and epiphyseal PET. This is MR imaging and transpose and basal ganglia level and the cerebellar level. And this is epiphyseal PET scan. It's MIP imaging and axial and coronal imaging. And I show you additional early perfusion pace image. It's the first 10-minute image. Okay, the question and to impulse. A, MR shows cerebellar atrophy. True. Yeah. B, MR show ischemic lesion in the stratum. No. C, epiphyseal PET show mild reduction of right putaminal uptake. You can see here and here coronal image. And D, early perfusion pace epiphyseal PET images show asymmetric reduction of the putamen and cerebellar uptake. Yes. The early perfusion image, the right posterior putamen show decreased uptake and also cerebellum asymmetric decreased uptake. So, we have just agreed the imaging finding. So, what is the most likely diagnosis? It's very easy. Yeah. Yeah. Correct. Multiple system atrophy, and clinically, this patient is cerebellar type. MSA is the one of the most common atypical Parkinsonism, and usually they show abnormal striatal uptake binding pattern. But sometimes we can experience that MSA, clinically typical MSA, especially cerebellar type, show normal striatal binding or subtle abnormality. So we studied the MSA patient with FDG PET and epiphyseal PET to test whether the epiphyseal findings according to the clinical subtype or FDG finding. So we studied 50 MSA patients. Among these, the clinical MSAP is 26 patients, and clinical MSAC 24 patients. Among MSAP patients show metabolic MSP that means the striatal FDG uptake abnormality, and metabolic MSA mixed both stratum and cerebellar show abnormal FDG uptake, and these patients show dopaminergic striatal dopaminergic neuronal loss. But MSAC, clinical MSAC, so among these, 87% show only FDG abnormality in the cerebellum, and it's clinically and metabolic MSAC show mainly normal striatal uptake pattern, but quantification is still lower. This is MSA mixed type, MSA-C, MSA mixed type, MSA-P type. So MSA-P and mixed type show abnormal striatal uptake binding, but the MSA show diffuse striatal uptake. So for the diagnosis of MSA, the FDG pad or dual phases epiphyseal pad is useful for the differential diagnosis, I think. Case 2. This is a 63 years old male who suffered from lasting tremor for 8 months and right arm and leg dystonia after fall down 30 years ago. The lasting tremor is the left side predominantly, but rigidity and bradycardia is the right side predominantly. Vision, others, MR and epiphyseal pad. This is the epiphyseal pad, MIP image and delayed image. And this is early phase epiphyseal image. What is the abnormality? It's as you can see, right side putamen show decreased posterior uptake, and also left side decreased uptake. And coronary image, you can see the left caudate nucleus also decreased uptake. In MIP image, right putamen show typical PD pattern, but left side stratum, this abruptly decreased the caudate and putamen. It's not typical PD pattern. In early perfusion phase image, right putamen show normal putamenal uptake, but left posterior putamen show decreased uptake, and also coronary image, caudate and putamen decreased uptake. It's not typical PD pattern. So what is the most likely diagnosis? A, CVD, B, MSAP, C, vascular Parkinsonism, D, Parkinson's disease with vascular Parkinsonism. A, B, C, D. A or D. Okay, let me show MR image. MR shows the old impaction in the posterior stratum and coronal radiata. Yeah, this region is resulting in the striatal decreased uptake. This side. But right side is normal on MRI. So, do you change the diagnosis? D? Yes. This patient is Parkinson's disease and vascular Parkinsonism. Yeah. Actually, we in old patients, we can frequently see small and large vascular disease on MRI. So the previous known impaction or small lacunar impaction in not only stratum but also the nigrostriatal dopaminergic neuronal tract may cause atypical pattern of striatal uptake on epiphyseal pad. And in this case, the thalamic old impaction showed the decreased uptake in the anterior part of the stratum. And in this case also, thalamic area impaction caused the posterior putaminal decreased uptake. Okay,